Hey everyone, so in this video here, we're going to explore two things. We're first going to explore the biomechanical relationships between the humerus and the scapula when we're measuring humeral internal rotation and humeral external rotation in the frontal plane when the humerus and the scapula are positioned more so in the frontal plane and the client is in a supine position. And the reason being is because this is going to influence how we describe the directional behavior of the segments. And it's also going to help us better understand how the scapula is going to move to facilitate humeral internal rotation or humeral external rotation. So we also, of course, have to consider the thoracic spine and rib cage here as well. But of course, this will be different to if we were to measure this in the sagittal plane, internal rotation, external rotation in the sagittal plane. So we're just going to use it to be a bit more clear as to how we can describe the directional behavior of the segments. But also it's important to understand this because it is important to understand how to get a better measurement of humeral internal and external rotation, because that's going to feed into the next portion of this video where we dig into the clinical reasoning process behind how we can understand what interaction is limiting overhead motion more. So when we look at overhead motion, whether it be motion in the sagittal plane, scapular plane, or the frontal plane, where we look at abduction, flexion, or motion in the scapular plane, we know that it's not just the humerus that dominates that motion, but it needs help from the scapula. So for every 3 degrees of shoulder motion, 2 degrees is expressed via the humerus moving relative to the glenoid, relative to the scapula, and 1 degree is expressed from the scapula moving relative to the thoracic spine. This is what's known as scapulohumeral rhythm, okay? So if we have an individual, let's say that is just limited in shoulder flexion, we want to try and consider, well, what interaction may be contributing to that limitation more, or where might we want to direct our focus more during the early phase of the rehab process when we're actually trying to improve or expand that shoulder flexion or overhead flexion or overhead motion, range of motion, okay? Is it between the scapula and the thoracic spine? Is it between the scapula and the humerus? So this range of motion or range of motion measurement here can give us a good insight into whether or not there is a limitation present between the scapula and the humerus, and that's going to influence then how we organize the humerus, scapula and thoracic spine as we're applying stress and load into the muscular tissues, okay? Because we want to be a bit more precise with where we're directing a load into the muscles, what behavior the muscles are expressing, what segment are we actually driving that motion through, where are we generating our force through, okay? Are we driving through the scapula, for example, or are we driving through the humerus as we move through that overhead motion? So we think it's important to be clear about that. So up first, let's briefly chat about this biomechanical relationship between the humerus and the scapula. So if we're measuring humeral internal rotation and external rotation in the frontal plane, when we're looking at humeral internal rotation, this would actually be a forward rotation of the humerus, okay? Typically, we think of humeral internal rotation as this inward rotation towards the midline. But when we bring the humerus into the frontal plane and we internally rotate, now this becomes a forward rotation. So if, for example, an individual is struggling to express that humeral internal rotation or forward rotation relative to the scapula, what you're often going to see is this forward rotation of the scapula. And you may see this flexion movement of the thoracic spine and rib cage, okay? It's important to consider that because that's why it is important to apply this anterior to posterior pressure through the shoulder so that you're bringing the glenoid into the frontal plane initially. You're maintaining that pressure as you bring the humerus through internal rotation. And you're looking for 70 degrees plus range of motion. Same thing when we look at humeral external rotation. If an individual doesn't have 90 degrees of humeral external rotation, what you're often going to see is the scapula posteriorly rotate. So that again, that humeral external rotation now is not just a rotation outward when we're measuring at 0 degrees of abduction. When we externally rotate, that's a rotation away from the midline of the body. But when we bring the humerus into the frontal plane, it's a posterior rotation. So it helps us make sense as to why that scapula may posteriorly rotate. And it's not necessarily a case where the scapula is going to contribute to that in isolation. It's going to be the lumbar spine that may extend to tip the thorax posteriorly, and that will drag the scapula back into more of a posterior rotation. Okay, so it represents that we may not have that relative movement between the humerus and the scapula. Okay, so we need to be looking out for these motions of relative or neighboring segments that may contribute to the motion of the segment that we're actually interested in. Okay, that's the key thing there. So when we're looking at, again, like I said, humeral internal rotation, this is one that's going to be very, very important because it will give us an insight into how well the humeral external rotators are lengthening. Your infraspinatus, your teres minor, your posterior delt, for example. And of course, with external rotation, it gives us an insight into how well the humeral internal rotators are lengthening, like your subscapularis, for example. Okay, so really important to consider that because that is an important interaction to allow for that lengthening behavior, that variable behavior of those scapulohumeral muscular tissues. Okay, so when we look at this within the context of a client that may have a limitation in overhead motion, and even just to briefly shift our focus for just a second and revisit a previous video where we looked at the Tyler test, okay, where we're looking at that horizontal humeral adduction. That's giving us an insight into these posterior tissues of the cuff as well. So looking at infraspinatus, posterior delt, teres minor, but looking at it more so through this horizontal plane. Okay, so we don't just have to look at this motion here. We can look at that horizontal adduction as well, because essentially what we're doing there is we're looking to see how well that humerus can horizontally adduct without needing the scapula to contribute to that motion. And that's why we're trying to keep the scapular position more externally rotated, so it maintains the glenoid facing into the frontal plane as we bring that arm across the body. And we're simply just looking for that humerus to break perpendicular with the table. Okay. So again, these tests just give us an insight into how well those scapulohumeral muscles are able to express a lengthening change. Okay. Okay, so let's look at this briefly within the context of a client that has a limitation in, let's say, shoulder flexion. Let's say they're limited at around 130, 40 degrees of shoulder flexion. And we're trying to understand, well, is that limitation being driven from a limitation at the scapulothoracic interaction or between the scapulohumeral interaction? Okay, now, key thing to consider first, from an IKM perspective, we always try to look at the sagittal plane first. Okay, and for the upper limb as well, looking at humeral or shoulder abduction is also important. But looking at shoulder flexion is something that we place a little bit more importance on because it requires the scapula to express a little bit more variability in its directional behavior. So during the early phases of shoulder flexion, to bring the humerus into the sagittal plane, the scapula has to internally rotate, then it upwardly rotates, and towards the end it externally rotates. Whereas looking at shoulder abduction in the frontal plane, the scapula will begin in external rotation, it will upwardly rotate, and it will stay externally rotated towards the end range of motion. So it doesn't have to express as much segmental variability. So we would never, personally, use this specific assessment of humeral internal rotation and external rotation to guide what we're going to do from a rehabilitation standpoint. We're always looking at the shoulder flexion range of motion, shoulder abduction range of motion, or even in the scapular plane as well. But mainly looking at shoulder flexion, that's more important for us initially, and then looking at shoulder abduction. And oftentimes what you're going to see is the client will move into the scapular plane when they can do either, when they can't do either. So they can't flex their shoulder or they can't abduct their shoulder. They'll just move the arm through the scapular plane because it requires less internal rotation of the scapula and less external rotation of the scapula. So it just reduces that challenge on how the humerus and the scapula are interacting with each other during overhead motion, okay? So let's say, for example, the client is limited with shoulder flexion. One thing that we want to do first then is consider how well the scapula is moving relative to the thoracic spine. Okay. Now, if you find that the scapula is not really moving well relative to the thoracic spine, then you may want to influence that first. Okay, so you're looking at the lengthening capacity of the medial scapular tissues, the rhomboids, the mid-trap, for example, other muscular tissues that will connect the spine, the pelvis, into the humerus, like your latissimus dorsi, for example. All those muscular tissues will be important to consider. From an IKM perspective as well, we always try to simplify the process of how we're restoring movement variability, and we always try to influence proximal behaviors first and move in a proximal to distal direction. Okay, so if you find that there is limitation between the scapula and the thoracic spine, that's what we want to influence first. Okay, what makes this complex is if you have a client, for example, and you're having them bring their arm overhead, oftentimes what you'll see is this, where the client will lift the arm overhead and they may elevate the scapula, but they may also move the rib cage and the whole spine in the opposing direction or in the backward direction to get that arm up overhead. So you may think that the individual has a lot of motion of the scapula relative to the thoracic spine, but it's actually the whole spine that is moving. So the individual may not have movement of the scapula relative to the thoracic spine or rib cage. It's because the thoracic spine and rib cage is actually moving to facilitate motion, to drag the scapular segment through a range of motion. So that's a situation where we may have to still work on getting scapular motion relative to the thoracic spine and rib cage, okay? But let's say, for example, the client had good range of motion between the scapula and the rib cage and thoracic spine. We weren't seeing any of this spinal compensatory motion to bring their arm up overhead. We can use this assessment here to get a quick insight into how well that humerus is internally rotating and externally rotating. Because if there is a limitation between the humerus and the scapula, then what we need to do during our rehabilitation is we need to try and reduce the contribution from the scapula and direct our load and stress and force into the muscular tissues that connect the scapula and the humerus. Your infraspinatus, your posterior delt, your teres major, your teres minor, all these muscular tissues will need, from our perspective, a little bit more focus in how they're actually dealing with forces, dealing with stress, but trying to do that in more of a lengthened manner, trying to pre-position those tissues in more of a lengthened manner, so that we're trying to reduce motion of the scapula and then allow for the humerus to move through a greater range of motion and then get load into those muscular tissues, okay? But one thing as well to consider here is that if you're struggling, for example, to see if the scapulothoracic joint is limited, what you can also do here is you can just check to see how well the humerus is moving relative to the scapula. You can also use the Tyler test as well, where we're looking at horizontal adduction, where we're trying to keep the scapula more externally rotated. So if you look back at that previous video in the shoulder section, we're trying to bring that scapula into an externally rotated position and then passively bring the humerus across the body to see, can it break that perpendicular position relative to the table, to see if these posterior scapulohumeral muscles can actually lengthen, okay? Because if the client has good movement variability there, if they have good range of motion between the scapula and the humerus, when you're looking at humeral internal external rotation and horizontal adduction, then it's more likely that the scapulothoracic joint is contributing to that limitation more, okay? But you may also have limitation in both. So if you have a limitation at the scapulothoracic joint, or between the scapula, rib cage and thoracic spine, and you also have a limitation between the humerus and the scapula, then what we would typically do first is challenge and target the most proximal interaction first. So we would target the scapula and the thoracic spine to get motion between those segments, to get us through that shoulder flexion range of motion. And then once we influence that to a certain degree, that's when we're going to place more importance on trying to get that variability between the scapula and the humerus, where we can actually reduce that motion of the scapula and allow for the humerus to express more motion. So we're getting more length into those muscular tissues that will connect the scapula to the humerus. Okay, so again, it is about appreciating what segmental interaction is contributing to the limitation more, but we also have to consider that both interactions may be contributing. But if that's the case, start proximally, then work distally. You can also work on both simultaneously across the rehab plan as well. Very often clinically, if it's not a significant limitation in range of motion, it tends to be one interaction that is contributing more to the overall limitation. But if you have a client that is significantly limited in range of motion, then it's more likely a case where you have to work on both. But we would almost always work in a proximal to distal manner as we're trying to restore variability across the shoulder complex. Okay, so again, just a couple of things there. Looking at humeral internal and external rotation measurements, why it's important to add that anterior to posterior pressure to bring that humerus, or to bring that scapula into the frontal plane, and why it's important to better describe the directional motions when we're looking at humeral internal rotation, which would be a forward rotation. Humeral external rotation would be a posterior or backward rotation. And we want to try and limit that forward and backward rotation of the scapula and the whole thorax. And then when we're looking at more functional behaviors, overhead motion, inflection, the scapular plane, and abduction, the frontal plane, we want to try and consider what interaction may be contributing to that limitation more. And that allows us to be a bit more mindful and thoughtful with what interaction we're placing more importance on, and how we're organizing those segments to be a bit more mindful as to where and how we're applying stress into the relevant muscular tissues. Okay, so we'll go through many more practical strategies as to how we can challenge that, but we have gone through some already as well if you want to check back through some previous videos. And of course, like always, hopefully it made sense, and if you have any questions, please let us know below.